Welcome to the CF Foundation's Virtual Patient Education Day, One Team Story, Raising the Bar for CF Care, a webcast supported through an unrestricted educational grant from Genentech. I'm Leslie Hazel, Director of Patient Resources at the CF Foundation. I would like to thank Cincinnati Children's Hospital and University of Cincinnati Medical Centers for hosting this webcast. This presentation will focus on quality improvement in CF care by having one center and the CF Foundation tell their story about how QI is working and how you can become involved in raising the bar for CF care.
Cincinnati Children's Hospital is an internationally renowned pediatric medical center. Concerned about clinical outcomes for CF patients, the institution has embarked on an ambitious redesign of both inpatient and outpatient services. The hospital has taken the unprecedented step of working directly with parents in an ongoing effort to redesign both the inpatient and outpatient care of their children.
Joining us from Cincinnati Children's Hospital is Honor Page, parent of a child with CF, and Jim Acton, physician and director of the CF Care Center at Cincinnati. Welcome, Honor and Jim.
Thanks, Leslie.
Why should people with CF care about quality improvement? And by the way, what is QI?
I've come to learn that QI is a process that looks at a system to see how you can make it better. And these concepts have been used for years in industries like the automotive industry, food processing, the airlines industries, with the goal of creating a safe, effective product. And I think we all like to think that when we need medical care, we're going to get excellent care. Unfortunately, there's been some research that has shown that sometimes that's not always the case. I'm thinking of the Crossing the Quality Chasm report by the Institute of Medicine that pointed out there are some defects in the medical system. So in Cincinnati, here at Children's Hospital, we've had the opportunity to do quality improvement and sit down and talk to each other about how we want our care to look and what might be the best care, and that's really important to me for my daughter.
So why is the involvement of parents and families and patients important in quality improvement? Can't the medical teams do this on their own?
You know, Leslie, that's a good question. The process of healthcare for individuals with CF is a shared process. It's an ownership that we share between the CF care team and patients and families. And so I think the best result when we're working on redesigning or improving that process is to work together.
Well, how did you set your priorities? Where did you start with something like this?
Well, that's another good question. You know, when we first, as a care team in Cincinnati, when we first started working on this as an organized project, we got together as a team and recognized that we really needed the input from patients and families. And instead of coming up with some complicated or intricate method to get that, like focus groups or a patient advisory council, we thought that it would be best and most efficient to have everybody sit at the same table and work together on the process. So that's what we did. We brought them to a meeting and we worked on what we called shared visioning, which was our process for deciding or looking at the components of CF care and identifying what was important in ideal care and what we wanted in Cincinnati. We then got together and shared that between the two teams, and that kind of started our collaborative effort, I think, which has been a core component of our work here.
Well, Honor, I have to ask, what was it like to sit at the table with your CF care team and have this shared vision of what CF care should be at Cincinnati Children's?
Well, initially I had some concerns about what it would feel like to be open and honest and share things. But the team really put a lot of thought into bringing us on and had certain things like first name basis only. There were a number of people at the table that I didn't even know that were different caregivers. So having that first name basis created a real comfortable environment. We did icebreakers, little things before the meeting so everyone had a chance to have their voices heard. And I think they really encouraged an open, honest environment, and I think that was underlined when Jim, as the center director, shared their CF data registry information, so that we had more information on what did our center's outcomes look like, and that made us feel like if they were open and honest enough to show everything about them, then we should carry through and be the same.
Okay, Jim, that leads me to say, what was it like to sit at the table with parents and to, show them what your data was?
We were nervous. I think the care team none of us were really sure how to do this, or what kind of reaction we would get, how to steer that reaction to be productive. And I think the results have been fantastic, and I think that it's strengthened not only our working relationship and quality improvement, but our care relationships as well. But initially, we didn't know how to do it. There was a lot of uncertainty, but we did recognize that in order to move forward, we couldn't work together as a collaborative team without being open and without sharing all this information, and we just had to take that leap.
Well, one person, when they registered, asked, how do parents know that their ideas will be taken seriously?
I can see how that would be a great question. Jim mentioned we did shared visioning, and that was, we had a chance for all of us to write down what we wanted the care to look like, and we saw our ideas integrated in developing the goals. One thing that comes to my mind was I was active on a self-management group, and I wanted to share the fact that when I took my dog to the vet, I always left with a summary of the visit and the medications and what to look out for and what we were going to do next. And I didn't really have anything like that for my daughter. And one of the physicians on the team asked me to fax my veterinary sheet so she could get a look at it and get some ideas. So I did feel that what we had to share was taken seriously.
How can patients and families participate? Who do they talk to get involved in their care center and quality improvement work?
Well, our situation was a little different in that we were invited to begin in this process. But if I was just learning about this information, I think I'd probably start with the CF Center director, because my thought is most likely he or she is already working on some quality improvement or would be interested in starting. So I would definitely start there, and any other member of the care team. And then I've also learned since I've been in this process that a lot of hospitals and clinics have quality improvement departments separate from the CF clinic that are really interested in bringing up the quality of their entire program. So perhaps a partnering of different resources would be valuable.
Honor, let me ask you the specific questions. What are the positive changes that you've experienced for your daughter because of the quality improvement work you've been involved in?
Gee, quite a few come to mind. Let's see. We've done increased surveillance on culturing, went from once a year to quarterly. We've been working more with our respiratory therapists, learning different breathing techniques that we never knew before. There's been an increased focus on nutrition, and Annie's kind of small, so that's important to us. We get reminders that we need our flu shots and that the vaccine is available. And there is a big push on self-management where Annie, without me, is working with different members of the team to set her own goals, which is really exciting.
Well, we've talked about the positives, but what have been the barriers or the challenges that you guys have had to deal with in this project?
I think, Leslie, there are a lot of things that come up along the way that can be viewed as barriers. I tend to like to think of them more as challenges as you put them, which leads us to think that we can overcome them. I think one of the things that everyone experiences is a time crunch and an effort crunch or energy crunch. There are limitations of resources. There are a fixed number of people on any CF care team. There are fixed numbers of patients and families to participate in this too. So there's always more work to be done, and not enough time and not enough people to do them if you want to look at it from a scarcity standpoint. I think an important concept is to think in terms of what we do have, and to look at it in terms of how can we make the most of what we have and make changes that will lead us to improving outcomes.
I definitely agree with you, Jim. I mean, being a parent of a CF child, time is very important to me, and I want to see good changes. I want to see them quickly. But one thing I have learned through this process is that small changes can really improve the quality. I'm thinking in particular of our team acquired valet carts for us for when our inpatient stays are over. No more balancing, juggling on a wheelchair and trying to get everything out. Now, that's probably not going to move a data point, but as far as the quality of the experience, it's tremendous. So small steps can mean a lot to patients and families.
Well, as a last question, what do the two of you hope will be achieved by quality improvement?
Well, my hope is that Annie's outcome is going to be better and that she's going to learn skills that are going to help her be more independent.
And you, Jim?
Well, I think, there's always a primary focus on wanting to improve the medical outcomes, the clinical outcomes, improve survival, improve lung function, the maintenance of lung function, and things like that. But I think we have to keep it in the context of exactly what Honor mentioned, that it is a big picture, and improving those outcomes takes some work, and we need to keep in mind the quality of life as well.
Well, thank you, Honor. Thank you, Jim. I heard them talk about the value of being involved in improving the CF care whether you're a parent, whether you're a member of the CF care team, or whether you're a person with CF. Also, there are no bad guys in the quality improvement work. It takes teamwork and it takes a partnership. It's critical to getting the improvements done. While the whole picture may seem very overwhelming, you need to take one step at a time, one piece at a time. Honor and Jim will be returning later in this webcast to tell us more of their story and experiences in raising the bar for CF care. I want to let you know, if you do not hear the answer to your question during this webcast, a written response will be posted and available in the archive version of this webcast, which will be available later this month on the CF Foundation website. Now we're going to hear another perspective of the QI story. We are going to talk to the adult CF program people at the University of Cincinnati. Please welcome Lisa Roos, an adult with CF, and Trish Joseph, physician and director of the adult CF program at University of Cincinnati. Welcome, Trish and Lisa.
Thank you, Leslie.
You know, we've just gotten done talking with Honor and Jim about what the pediatric clinic is doing, but what are you guys doing at the adult program, and how does it differ from the pediatric program?
Well, I'd like to say that there are actually a lot of differences between the adult and the pediatric program. And I think that if you look at quality improvement across the country, there will be lots of different approaches to the problems. There are probably as many different approaches as there are different CF centers. There's not necessarily one way that's right, and everybody has to fit the needs and desires to their particular program. That said, Children's got started with the help of a Robert Wood Johnson Foundation grant and with the support of their administration, and got into this fairly easily. I think when you're taking care of adults, there are a lot of obstacles, that some of which are similar to the problems that pediatric programs have, and some of them are much different. I think that the finances of an adult program are much more difficult because you're a small population competing for adult resources that may not be as easy to obtain, and the hospital administration sees the CF population as a very small population and part of a bigger a bigger issue, and so may be more inclined to pay more attention to other problems than to CF. There also is the issue of time. Many adult caregivers have other obligations. Many are pulmonologists who work in intensive care units and the likes, and don't just do CF as their primary commitment. And finally, CF patients, although I think that they care about quality improvement and getting involved, I find that a lot of patients are willing to do almost anything. People are willing to do things for their children that they may not be willing to do for themselves. And so when you ask 3 times a day airway clearance as part of a quality improvement program, you'll find that parents will be more than glad to do it for their children, but adults who have competing needs, they have jobs, they have their own children to take care of, things like that, may not have the commitment to programs in terms of becoming involved and in terms of doing what it needs to have self-care. That said, the way we approached it in Cincinnati started off with individuals and trying to address problems that individual patients had on a sort of a one-on-one basis. Then when we were invited to join the Learning and Leadership Collaborative sponsored by the CF Foundation, we were taught formal techniques to address quality improvement in the same way that industry does, and have applied the quality improvement techniques to bigger projects. We still have a lot of our quality improvement that's addressed at an individual basis or more one-on-one, but we also are now doing the more formal, larger projects as well.
Well, Lisa, what quality improvement work have you been involved with?
I've actually been involved with several. My first one started with Trish here. In '99, when she came on, I was had this concern about how the port procedures were being handled. And because I was used to how they were at Children's, and I had just come to the adult hospital. So we worked together with the CF nurse and Melanie and talked to the staff over at Children's for them to come over and do an in-service for the UC nurses and staff. And still today we're using that same procedure that we started back in '99. Also, I was involved with working with the dietitian to have a separate menu write-in so that we weren't locked into the yummy 3 choices that they give for breakfast, lunch, and dinner. I'm also currently doing the newsletter for university, the adult center, that is distributed to every CF patient, adult CF patient at their care center quarterly.
Well, you are doing a lot. Let me ask this question. How did it feel to sit down patient to doctor and talk about the issues? I mean, to approach your doctor and say, you know what, don't like the way you're doing the central line dressing changes, this has got to change. How'd you work through that?
It was very intimidating, but Dr. Joseph is very easy to talk to. And so, voicing my concerns to her, and then, she told me the proper people to go through. And so it was very intimidating. You feel, for all these, in the past, it's always, you felt inferior to your doctors, and that's not so much the case anymore.
What about you, Trish? How did it feel to, kind of go to any of your patients and go, this is a problem we've got to work on?
Well, I think that especially when you're dealing with adults, everybody knows that there are flaws in the system. And you can either try to hide the flaws, or you can be open and admit that there are flaws and that you need to deal with these and address them. And I think by inviting the patients to become partners and help you address the issues that you need, it actually, although it may feel awkward at first, probably the hardest thing is going transparent with some of your data, your CF registry data is probably the most awkward thing to do, and the most anxiety-provoking. But in terms of partnering with patients to try and improve care, I think that's actually very easy. You find that patients are often, interested and eager to help. And the other thing is that only by talking with your patients do you find out what it is that they want. What we as caregivers perceive as, what the patients want or need isn't always. We may think that they want access to all their lab data within 3 days, and in fact, they want a better parking place. Yeah. So by talking to your patients, you know more what they want and what's important to them.
Well, here's a question that was submitted by a parent, and I'm sure adults have the same concern, and I know, being an employee of the foundation, I have received and talked to people who have this question, and that is, how can we become a part of this discussion with care providers at our own center without provoking defensiveness of our CF care team or being thought of as a complainer and thus not getting the level of care we should get?
It all goes with attitude and body language. Don't go in, and start complaining. You need to be very open-minded and state your position and ask, how you can help them. Not, this is my problem and how are you going to fix it?
I have to agree that some of my suggestions revolve around the fact that it depends on how the issue is expressed. If you go in hostile and critical, you're going to be received, obviously much less open than if you walk in and say, this is a concern I have some questions, could you, work with me on this? Also, I think that if you're willing to look at all of the different aspects of a problem, not just your side of the problem, but the administration and the physicians and, the process and try to understand the whole thing, that helps. And finally, it's always helpful if you come in with, instead of I don't like the food, to say I don't like the food, but here are some suggestions for how we might make it better. Can I work with you to help this happen? I think is much better received than just a complaint, but to be part of this, to offer ideas for how to come up with a solution.
Well, from your perspective, both of your perspectives, what is the biggest challenge for doing successful quality improvement work?
I'd have to say that it's a combination of time and money. Certainly in an adult program, the funds are limited, and we could do a lot to make things better if we had unlimited resources. And I think that physician time, personnel time is stretched, and it's difficult to accomplish all that you need to do in a day, and to find the time to work through these programs. It helps if you take them a little bit at a time, but coming up with the time and the resources to get started is probably the hardest. How about you, Lisa?
It's the same on the patient's level. It's time and money, just from a different aspect. I don't work. I'm stay home with my son, and my health is a big concern. When 2 weeks ago I was in the hospital, and so I wasn't even sure if I was going to be able to be here. So the whole
And trying
issue.
to get your life coordinated.
Yes.
And still get your health care
Yes,
done.
I wouldn't be able to do it without my family.
Well, that's good. It's good that you have some support. Last question. What do you hope will be achieved with quality improvement?
Well, I'd like to see, certainly the survival information suggests that you can improve the life expectancy, and I'd like to be able to improve the quality of life of our patients, both in terms of the time that they spend in the clinic and the kind of life that they have outside of healthcare, giving them longer times out of the hospital and away from IVs, that sort of thing, and also just to provide them hope that there's something positive for the future and that things can get better.
Well, thank you, Lisa. Thank you, Trish. They will return later in this webcast to tell us more. Their story is an example of how quality improvement in CF is done differently at different clinics. Just like your CF health provider prescribes different therapies for different people in order to meet their individual medical needs, quality improvement varies because each center has different staff, different patients, different families, and a different organization. But together, they can work to raise the bar for CF. Next, we want you to hear what the CF Foundation is doing to take quality improvement to all the care centers. It is my pleasure to introduce Bruce Marshall, Vice President for Clinical Affairs and leader of the CF Foundation's Quality Improvement Initiative. Welcome, Bruce.
Thanks, Leslie. It's great to be here.
Well, why is the CF Foundation working on this, and what future does it hope for someone with CF?
Well, we think it's important to focus not only on the future, and we're working hard on discovering new therapies and developing new therapies, and that's core of our mission at the foundation, but we also want to do our best with what we have available right now. So we want to make sure we're using the tools and approaches that are currently available in the most effective ways in our care centers, and we think that this is important for patients and families.
So what's the foundation doing to support quality improvement at every center? For example, how is this going to be funded or paid for?
It's a good question. The foundation has really been about quality improvement for a number of years. In the 1960s, the Care Center Network was started, and the foundation has continued to fund that, upwards of $10 million this past year. And all of our care centers get grants, and they can use that money to fund staff that are key for their operation, or use it also to send personnel to the North American CF meeting to get the latest and up-to-date information. So, we're doing a lot in quality improvement and have done that over the years. More recently, over the last few years, we've really brought methodologies of quality improvement that have been applied in other industries to healthcare. And we've started to train our care centers by way of learning collaboratives so that they have the latest techniques and methodologies that they can apply to healthcare to improve it even faster.
So have all the care centers received this training, the training like what Trish described as the learning collaborative?
Not all of our care centers have had this training yet. We have upwards of 120 care centers scattered around the country, and we've trained intensively approximately 30 to 35 at this point. Another set of our care centers have had other training by way of regional consortia. But all of our care centers have been exposed to these ideas by way of the North American CF meeting, and we've had center directors meeting at last year's meeting and exposed them to a lot of these ideas. So there's, at this point, a wide range of experience in quality improvement, to some centers like Cincinnati that have had extensive experience, and others that are just getting started.
Well, just to ask, when did the foundation start doing this training?
The more intensive training really started in late 2002, and it continues today. We're currently working with 12 care centers, and they're doing projects, quality improvement projects. We'll be bringing them back together this June. So it's really been since late 2002 that we've trained these 35 care centers. And now what we have is a plan to reach out further and faster by way of electronic collaboratives to train all of our care centers.
So this is not an instant, I go to a class once a week for 10 weeks and I'm done. This is a process that it's going to take some time and involvement for it to spread throughout the network, right?
It does take time, and some of it is common sense, but some of it requires some education, things that we didn't learn in medical school or nursing school. These are really new ideas, new concepts, new methodologies that we really have to re-educate our workforce, and it does take some time.
Well, let me ask you a question that came in, and that is, how do patients and parents ensure that their CF Care Center providers are in touch and using what's described as best practices?
Best practices, it means different things to different people, and we don't really have a firm grip on what best practices are. We're trying to get at best practice by a process called benchmarking, looking at centers that seem to have the best outcomes or better outcomes over time, and then study and see what is it that they do, what are the practices that lead to those outcomes. But it looks like it's not going to be as simple as, for example, the way they use a particular therapy. It's probably going to be, the answers are more complicated than that, the way they relate to their patients, so the communication back and forth, sort of the complex issues like that really lead to better outcomes.
So is information that, say, Cincinnati learns in their quality improvement process shared with all of the care centers?
In fact, I was just talking to Jim and Honor about this earlier. We do want to capture what they've learned here at Cincinnati. They've done some of this benchmarking where they've called other care centers and visited other care centers, and they've shared with us some summary information, and we've shared that on a limited basis with our center committee. But we want to put it in a format that we can get the word out to all of our care centers so that everybody can take advantage of the knowledge. The idea is that every care center has something to offer, and it's sort of an all-teach, all-learn sort of model. We just want to facilitate sharing of this information.
Well, I know the CF Foundation accredits CF Care Centers. And doesn't going to an accredited CF Care Center mean you're getting quality care?
It does. Accreditation is really an important step for a center. What it involves is a new center application. It's a detailed application. Our center committee, which is comprised of center directors and adult program directors, reviews the application in detail. Then there's an actual site visit by 2 members of the committee. They spend a whole day at the center and look at the sweat test lab, the microbiology lab, visit with the personnel, look at the facilities, meet with the administrators of the hospital. So it's a pretty detailed process to look at what's going on at that center to ensure that quality care is in place.
Well, a question that came in is, what do rankings mean regarding CF centers? Are there some top 5 or top 10% care centers?
Well, rankings, I think it reached the news in the New Yorker article that was published several months ago. There was some hint or suggestion that the foundation has rankings of centers, and that really is not the case. What we have is a patient registry, and all of our care centers submit data about practice patterns and outcomes as it relates to their patient population. We roll that data up, aggregate it, and produce a report, and part of that is a center-specific report that we feed back to all the care centers. But that data is just raw data. It describes their nutritional outcomes, their pulmonary outcomes, and their practice patterns. But it's not really adjusted for some of the key things, number one. Number two, we don't roll up all of those things into a ranking system. So we don't have a top 10 of care centers. We see some care centers do well in pulmonary over the years, and some do better in nutrition, but there doesn't seem to be 1 or 2 or 10 care centers that are just outstanding across the board, and they're always there.
Well, if one center's doing better nutrition and another's doing better pulmonary, do we know why they do differently? What are they doing differently to do better in nutrition or do better in pulmonary?
That's part of the benchmarking process that we're going about now, is to really try to understand what is it that underlies those outcomes. Can we put our finger on what is it? And again, I don't think it's going to be something simple. I think it's going to be complicated. This variation is important, and there's information embedded there that we need to tease out. But it's not going to be simple. It's going to be a little more complicated. But we're committed to try to find that information out and share it.
Well, when is this data going to be shared? When is it going to be available to patients and families?
You mean the rankings for care centers and the data?
Well, just the data of how well an individual care center is doing.
Well, what we are committed to, first of all, we believe getting this data out in the public domain is the right thing to do, and we think it's going to help us get better faster. We already have a good system in place. We think it's going to help us move faster. What we have in place is a process that will get us there sometime in the middle of 2006. And you might ask, well, why does it take so long? Why can't we just put the data out there now? Well, the reason is the data we have now is raw data. It's not adjusted for some important things like socioeconomic status. We know that in healthcare, just like in education and other things, more affluent people tend to do better than poor people. So it's not really fair to compare a care center from a place that's in suburb of, say, for example, New York City that cares for a lot of affluent families, despite the fact the cost of living is higher there, as compared to somewhere in the Deep South, for example, where there may be poorer families there. Just by virtue of socioeconomic status, that care center is not going to have outcomes that rival those of a care center that takes care of affluent families.
So patients and families can expect to hear the data in 2006 about this information and quality care at the different care centers.
We're targeting for middle of 2006, and what we have is a plan and a process in place where we're working with a group of experts right now. In fact, we had a call earlier today with this group. And these are epidemiologists and biostatisticians that are helping us figure out what are the proper adjustments, how do you do those adjustments, how do you display the data. Once we have the recommendations from that group, we're going to take it back to our center committee, review it with the leaders that sit on that committee, like Jim Acton from Cincinnati is on that committee, get their recommendations, and then take it to our whole center network, because what we want to do is make sure everybody is aware of where we're going and how the data is going to look and how it's going to be presented so that there's no surprises.
Well, you've done a great job of describing what the foundation is doing to get information to the care centers, but what's the foundation doing to get information to patients and families?
It's a good question. It's really important to educate patients and families about this disease. We want patients to come to the care centers activated and educated and ready and willing to ask the important questions like we've heard earlier today. But I think that's a better question for you. As Director of Patient Resources, you can give a better answer to that. So I'll turn the question back to you.
Thanks, Bruce. Education, this webcast is an excellent example of how we're getting information directly to patients and families. Bruce also mentioned the patient registry, which is available on the CF Foundation website under the publications section. If you want to learn more about the New Yorker article that Bruce mentioned, you can go to the general news section and click on information the CF Foundation has available about the article, and then click on the link to the New Yorker article and read it directly. Also on the CF Foundation the website, under the Living with CF section, is a Quality Improvement in Care fact sheet. So you can learn a little bit more about quality improvement that we don't have time to talk about tonight. Also, if you want to learn about the best practices and the standards of care that have been set, I encourage you to watch some of the other webcasts that are available on the Foundation website that talk about nutrition, how to avoid germs in CF, and what the gold standard of care is. Remember, resources are not just paper, they're not just internet information, nor are they just webcast. The most critical resource are the people involved. Start the conversation about your care and quality improvement with your care center. take the first step. Now, we are going to talk with Trish and Jim, who'll share their pearls of wisdom and experiences about QI, working with parents and patients, and to raise the bar for CF. This is quality improvement from the care center perspective. Welcome back, Trish and Jim. So we've talked with you two, physicians. We've talked with Lisa with CF and Honor, who's a parent, but are you guys the only ones involved in quality improvement work? Who else is involved in this whole process?
Well, Leslie, as we talked, and I think Lisa and Honor expressed it very well, their involvement and contributions are critical. I think that they make an incredible component, an incredible contribution to the process of improving CF quality of CF care. I think, though, that there are many other people involved. I mentioned earlier about the many different multidisciplinary folks involved with the CF care teams. I think that people beyond the CF care teams in the institutions supporting those care teams are also important, including the administration. I think also that whether there are people within the institutions or people within the CF Foundation and the CF community who have experience and knowledge about how to change systems. I think that it's important that we take advantage of individuals who have those skills as well.
Well, what motivated you to participate in this work, and what's the most rewarding aspect of quality improvement?
Well, I have to say that, I began addressing initial patient issues, but what really got me involved in quality improvement was a combination of becoming aware of the survival statistics that patients who deal with their nutritional issues and diabetes and early screening and the likes actually have an improved longevity, coupled with the ability to make the clinic and the CF care more efficient, are really what's behind my interest in quality improvement. And then becoming part of the Learning and Leadership Collaborative taught me the tools that we needed, and also other team members to really implement the quality improvement.
Well, here's a question that came in and from actually a care center. How can care centers provide a continued high quality level of care with each person they see, and the person seeing everybody on the care team without taking so many hours out of the patient's day when they come to clinic?
You want to answer that one, Jim?
Sure, I'll tackle that one. Leslie, it's a really important question. And I think what we're finding in Cincinnati is many of the things that we're addressing, many of the changes that we're tackling to improve the outcomes actually are increasing the aggressiveness of our care. They're increasing maybe the amount of time, the amount of visits to the clinic, perhaps the amount of interventions that they do at home, even by way of airway clearance treatments or other therapies. Now, I think it's important that we as the care team in particular keep in mind the impact that has on the patients, the families involved in that day-to-day care 24 hours a day, and we have to keep in mind the importance of efficiency. Now, what's the answer to how we keep that from running out of control and slow that freight train down? I don't know yet. I think it's important, though, that we keep it on the table, and as we move forward in improving the outcomes and improving the care, we also keep in mind the importance on their lives and improve the efficiency of that care as well.
Well, here's another question that came in. How can CF care providers aggressively seek to engage patients and families in quality improvement work?
Well, I would say that for me, what has helped is that when patients come to me with an issue that they would like to have addressed, I invite them to become part of the process. Sometimes that's as simple as helping by making the administration aware of the problems, because administrators often listen to patients before they listen to physicians, and to become a partner with them in dealing with the process, not just to look at them as someone coming with another complaint. And the other thing that's important is to listen to what the patients have to say, to be open to their suggestions, and to try and work with them in a partnership relationship, and also to be not defensive about your data, to be transparent with where your center stands, and to say, look, I understand that there are issues that we need to deal with, and why don't you help us deal with this?
So is this like a single project and it's done and there's no more to do, or when are you guys going to be done with quality improvement work?
I have to say that quality improvement is a journey and not necessarily the destination. You may work on an individual project and, the example that I'll use is that we just recently tackled trying to make sure that the adults were and older patients were screened for osteoporosis. And although the project had an end, one of the biggest challenges to quality improvement is to sustain the changes that you made. And so we got everybody screened, but now we need to make sure that the screening is ongoing, and that's a real challenge. And so this is an ongoing process that hopefully eventually gets folded into the clinic work so that you don't particularly notice that you're doing all of these quality improvement things, but I don't think that there really is an end.
So it almost sounds like, and correct me if I'm wrong, that quality improvement is a change in practice. It's a change in your process that you do at clinic.
I would agree. I think that there are a couple of different components that go into it, actually many different components that go into it. And you mentioned a couple of those. Some of it's around a philosophical change, how we collaborate, how we interact and relate with our patients and families, not to them, but with them, both through care as well as working on quality improvement. There are also pieces that have to do with our practice, how aggressive are we being, what should our goals and our outcomes, our expected outcomes be. We kind of affectionately refer to those as where we set our bars. And then there's the process piece, how do we do that? How do we deliver the care?
Well, as the last question, what pearls and gems would you give to other care center providers who are interested in doing quality improvement work?
Well, I think, Leslie, there are many things that I think we'll continue to learn through this process. A couple of things that I would mention, and I think Trish mentioned it very well just a few minutes ago, was the concept of being open, being transparent, and avoiding the defensiveness that can come about when we're looking for excuses, or we're looking for an explanation, maybe not excuses, but looking for an explanation for why we think something happens. Rather, let's work together and accept the fact that we can make an improvement, and then let's move toward that. I think in the next step then is also very important, which is begin taking those steps. The first steps don't need to be leaps and bounds, and in fact, I think many times we bog ourselves down trying to make those first steps gigantic and make us, get to the summit with the minimal number of steps. And I think if we just start taking the first few steps, it will get easier and easier, and all of a sudden we'll find ourselves at the top.
I'm sorry, go ahead.
Well, the last thing I was going to mention, and I think is also very important with respect to the care team, as well as patients and families, is to recognize and celebrate the successes when you reach them. I think that it's important to acknowledge when there's progress being made and when you're making changes, and to celebrate them together as a team.
From the adult perspective, what would you say would be the pearls?
Well, I agree with all of the things that Jim has said. The other thing that I would say is that for CF care centers, a lot of your patients, particularly the adult patients, but parents as well, bring some unique skills, and you may think, well, let's get them involved with, things that directly involve patients, like how to flow through clinic or something like that. But frequently, patients bring other skills. They bring computer skills, they bring business skills, management skills, and things like that you may utilize in ways that you didn't necessarily think would be a way to utilize a parent or a patient. For example, Lisa's newsletter is something that she does on her own, that if the center tried to put out this newsletter, it would be an overwhelming burden. But Lisa's involved and interested, and she's brought the skills to put together an outstanding newsletter that's a wonderful resource for our patients that we would otherwise not have the time and energy to do. So, recognize that it may not be what you think patients are going to bring to the table. They bring other skills that, computer skills, things like that you may use. The other thing is to mention to the patients that it's really important to come with ideas, not just with complaints, and to be willing to look at all of the aspects of a certain problem that you're trying to deal with. Both the care center teams and the patients need to look not just as how something impacts them, but to look at all of the aspects of what's involved. And then finally, just to roll up your sleeves and jump in.
Well, thank you, Trish. Thank you, Jim. As we've heard, quality improvement is complicated, and there are many different components. This presentation focuses on just one, and that is involving patients and families in the quality improvement work. You can learn more by also reading the fact sheet on the CF Foundation website. Also, don't forget, talk to your CF Care team about quality improvement and what you can do. Before we start our last conversation, I wish to thank you for watching. Honor, Lisa, Jim, Trish, and Bruce for their hard work to put together this presentation and being on camera, Cincinnati Children's Hospital and the University of Cincinnati's Medical Center for hosting, Deanne Evans and Genentech, Rick Vasta, the technical crew, Carolyn Haberset, and the CF Foundation for helping to tell you one team story of how quality improvement is raising the bar for CF care. Now, the best for last. We're going to hear the gems that Honor and Lisa have learned about quality improvement and working with their CF care team. This is quality improvement from the people that CF impacts the most. Welcome back, Honor and Lisa. Okay, now you can give me the skinny. Jim and Trish are not here. You know, what motivated you really to do this?
For me, it was the opportunity to share my concerns and to give my input on the whole QI process.
And you,
And for
Honor?
me, it was wanting to impact Annie's health, that we work so hard every day to keep her well. This was just another way.
Well, how has your interaction with your care team changed since being involved in quality improvement?
It's definitely become more personal. You know, at first it was the doctor-patient relationship, and then the more you talk, the more personal it becomes, and then you realize these people actually care about you, and you know that they're going to do their best.
Well, it sounds like the quality improvement team is large. So what role do patients and parents play in the team?
Well, I think we have the most to gain, first of all. So we're going to be bringing an energy to it that's going to be sustained and hopefully help carry along, because change is difficult. We're also kind of a mirror for our team to see how changes are working. We can give feedback and not only help create change, but then help share how it may be successful or not.
Well, how should patients and parents approach their care center to ask about quality improvement or being involved? Who should they talk to?
Start with the person you feel most comfortable with, and then go from there. You can find out who's the chain of command and where to go. But definitely start with the person you feel most comfortable with.
And I think it's important. I think we heard it when Trish and Jim were speaking, but this is not a place for complaining or whining. It really is a non-adversarial relationship. These people have always been there to help us, and this is just another way they want to help us.
Well, what barriers might a patient or parent encounter when they first want to be involved in the quality improvement process, and what might they be able to do about it?
Well, I would say just keep asking questions. If there is a quality improvement program in place, you'll probably find your way into it. If there isn't, just keep asking questions and see what you can find out. And don't feel intimidated. Parents and patients can and make change.
Well, now how long have you guys been working on quality improvement?
Let's see, we started our program in 2001.
Wow. And what about you, Lisa?
Informally, we've been working on it since I came to the center when I was 18, and I'm now 28, so it's been quite a while, but we've actually labeled the process right around the same time, 2001.
So this is truly an ongoing work that everybody's involved with. You know, what does the road ahead look like? Where is it going? Is it a straight road? Are there more challenges to overcome and work around?
There's many challenges as far as, you know, right now it's the people that are taking care of us, the doctors and the nurses, and the patients, you know, we're all working together, but it needs to go beyond that, you know, all the way down to, you know, the housekeeping when you're in-house, you know, the dietitians, you know, and the dietary people, you know, just the staff all the way from the very, very bottom, no matter how minuscule they think they are, they're not, you know, and if everything is good from the bottom all the way up, then it's going to improve the quality of the life that we have.
Let me make this a little bit more personal. What changes do you expect to see in your daughter's life, Honor, because of quality improvement?
Well, I'm hoping that her experiences at the hospital are safe and she gets the best care available. And one thing I'm already seeing is the emphasis on this concept of self-management, and I'm really hoping that this work will lay a foundation for our whole life.
Now, what about you, Lisa? What changes do you expect to see in your life because of quality improvement?
Well, that's a little hard to answer, but I definitely, just to know that they care, that's the main thing, and to see that, there is an actual concern, and, that they're not putting on airs. That's the main thing. And through it all, I think it'll definitely, help expand the quality, our life, but definitely, the quality needs to be there, more important than the length.
So we've talked about what role patients and parents play. We've talked about how do they ask to be involved. What are the concrete things that patients and parents can do to get involved and work on quality improvement at their care center?
They just need to do it. They just need to get involved.
That's right, make your presence known.
So just ask those questions and keep asking those questions.
Until you get the answers you want.
Well, here's a question that came in from a care center. How can CF care providers enhance patient participation in decision-making, being more involved in their health care or quality improvement work? What tips could a care center use to help get their patients and families involved?
Well, since it's a fairly new concept, for UC, we can put it in the newsletter and get it out there, what QI is, and, that it's, participation is wanted from everybody, and then hopefully that would start getting, people to bring up more questions and more concerns and be more compliant with, everything.
And I'm reminded of a diagram I saw somewhere along this process of an iceberg where the part that's sticking out of the water says patient education. So I'm imagining that's your pamphlets and your one-on-one teaching and the videos. Yet under the water, there are many different components to that iceberg that I think reflect what people have to deal with to make decisions about their care. Coping skills, interpersonal relationships, financial concerns. These are all things that are hard to work with. I think the care team has a challenge there. But I think recognizing that it goes deeper than maybe just traditional patient education, that to really develop these self-management skills to help them have a better understanding and be more independent and ask the questions and get involved requires maybe a bigger focus.
So the care center providers need to not just think by telling you about the therapy and what to do and educating about the disease of CF, they need to take into consideration that, you have jobs, you do have to work, you may have a child that you have to take care of, you have a dog that has an injury that may take some time. So there's other parts that you have a complete life, and health care is not the only thing that you're trying to juggle in your life. Is that
That's right,
correct?
yes.
Well, the last final piece, what are your gems and your words of wisdom that you will give to every patient and family watching this webcast who want to participate in quality improvement at their care center?
Mine is more advice. This is a chance for us to be heard, and we finally have a voice in how everything is run, and we need to speak it.
That's great. And I guess I'd add a couple things. Remember, don't feel intimidated. I remember starting out feeling that way a little bit, but as we progressed, I learned that our care team probably has as much admiration for us as we do for them. So they're really there to listen and learn. And also, don't be worried if there are bumps along the process. There's some challenging work here, and there are times where you might feel frustrated, but hang in there, because things tend to work themselves out if you put enough effort into it.
So is that all? Did you have another gem? I don't want to lose one.
I was thinking I want people to realize the value in things they think about. I mean, imagine patients and parents when they're receiving their care, they might wonder about some things. I remember I used to wonder about, how do they clean this PFT lab? When Annie would go in for her blowing. I mean, I'm sure they did, or I thought they did, but I guess I wanted to know how they did it, and were they concerned about that? So I imagine there's patients and parents out there that have occasionally wondered about things. There's some value in that. You should share that. And lastly, just remember what a terrific resource your team is. I mean, these folks get up every day and come to work to help our children and adult patients and they're there to help, and together we're a great team.
So, I mean, it really sounds like quality improvement, number one, is not a one-time project. It's a process and it takes time. And number two, it's very important to work as a member of the team with your care center and to clearly communicate, well, what are you dealing with and what are your issues to try and resolve? And don't just complain, but come with some ideas and some potential solutions. Well, I thank you, Lisa, and thank you, Anna, for joining us and sharing your experience and giving words of wisdom for others. You know, we've heard a very incredible story tonight. It amazes me that one center story can say so much about how people with CF, their families, and their healthcare providers can make a difference and change the healthcare system to make it work better. To find out how you can be involved in quality improvement work at your CF Care Center, contact a member of your CF Care team.
Empowering families to help redesign medical delivery systems is a major transformation for any healthcare institution. For Cincinnati Children's Hospital, it is the essential first step in the journey to improve the quality of life and increase the lifespan of children with cystic fibrosis.
We want to keep them alive as long as possible. We want to have the best health care that we can. And some of us have made the decision to help as much as possible to get a better healthcare system.
Quality improvement is a work in progress. This will require continuous learning and work for all concerned. Begin building the partnership with everyone: parents, patients, doctors, nurses, therapists, dietitians, and social workers. It all starts with a conversation and a willingness to get involved. We hope that you will begin the conversation soon. Are you or someone you know a hero of hope? Heroes of Hope Living with CF is a national program created to recognize and award those individuals with CF who inspire others with the disease. Through their positive attitude, proactive role in keeping themselves healthy, community service, and unique achievements, Heroes of Hope are role models to others in the CF community, proving that having CF does not stop you from trying to reach your goals. To learn more about Heroes of Hope Living with CF, please visit palmazine.com and click on the Heroes of Hope button. Nominate your hero today.